normal heartbeat that you feel, or it can represent an arrhythmia, and it can be a sign of something which carries some risk. Often it is not anything risky at all. The list of things that can cause palpitations are many. Some people, a simple drink of alcohol can set off arrhythmias that they feel. We call these lone fibrillators. In others, being anxious can set off palpitations. Mitral valve prolapse in women is a notorious cause of palpitations, where the valve, as it prolapses, pulls on the papillary muscle and often sets off arrhythmias. Arrhythmias in the face of coronary artery disease are clearly potentially a dangerous thing. So there are many, many causes of palpitations, and it really depends upon is there an arrhythmia first and foremost, and if there is, what is the arrhythmia, and is it a dangerous arrhythmia? Things such as thyroid disease can cause arrhythmias, and then you try to get to the bottom of what's causing it, and then that really determines whether you do anything about it more than what has been done already.
Sure. I mean, since he's talking about nocturnal or nighttime arrhythmias, one of the as an extension to what you already highlighted, is certainly sleep apnea seems to be emerging as a well-recognized cause also to precipitate various nocturnal arrhythmias, both slow and fast, sometimes dangerous heart arrhythmias. And if left alone, the arrhythmias can, if they're persistent and rapid, depending on the cause, they can weaken the heart muscle and lead to, over a period, heart failure, and the arrhythmias can be dangerous. So it does have to be investigated by monitoring it by the so-called Holter monitor, which could be worn up to 24 hours to really detect whether there is anything dangerous, or is it just a skip beat now and then, or is it more persistent, more rapid and dangerous varieties of arrhythmias. And based on that, one can investigate a little deeper to get into the causes. So the answer to that question is that you have to dig deeper to really know the cause, and then the treatments vary. So at this juncture, we'll take a brief break. We are roughly about half a time in this show. We'll take a few seconds break here, and we'll come back to our live call-in show. I want the audience to stay tuned for and call us with any cardiovascular questions they have.
Who can you trust to use the latest technology to prevent stroke? Blockages in the carotid artery of the neck can stop the flow of blood to the brain, causing a stroke. Until now, opening these blockages required surgery with general anesthesia and long incisions. Today, there's a new way to treat the problem of carotid artery disease in some cases. A simple procedure uses a small needle stick in the groin, and a guide leads a tiny cage-like stent to your carotid artery, where it expands and restores blood flow. You remain awake, and recovery time is much shorter. Who can you trust to know the signs of stroke and use the latest technology to stop it? Cardiovascular Institute of the South trains doctors from around the globe to perform this latest procedure to treat carotid artery disease. Cardiovascular Institute of the South, trusted by physicians from around the world, trusted by people like you. Call 800-425-2565 or visit us at cardio.com.
Welcome back to our live call-in show, monthly live call-in show from Opelousas General and Cardiovascular Institute of the South. And I'm Dr. Verena, and I have with me Dr. Craig Walker, who is the founding member and president of Cardiovascular Institute of the South. And we have been continuing discussion on issues pertaining to the vision of Cardiovascular Institute of the South, how we have enabled to bring a comprehensive set of cardiovascular services, both at the level of consultation and at the level of diagnostic services in the office, and finally translate into state-of-the-art interventional procedures as it comes to the hospital setting. And we have dwelled a little bit on the consultation, we have dwelled a little bit on the diagnostic services, and I specifically wanted to, one of my fascinations, which I'm sure came and was inspired by your fascination, is to the development of a very comprehensive. Most cardiologists, most cardiac practices are confined to having an echo technician, whereas in our offices we have a highly comprehensive vascular technicians who are multidisciplinarily trained to the point they can do simple ankle brachial indices all the way from head to toe studies. What led to the investment to develop these state-of-the-art vascular labs, which are the backbone of a cardiovascular program?
Well, obviously, we have diagnostics in our office that many hospitals, envy in the past in terms of 64-slice CAT scanners and other things such as that. And a big part of that is we have a tremendous interest in peripheral arterial disease and peripheral venous disease. Part of the interest there came from the fact that this is a very common disease and that people with leg blockages usually, not sometimes, but usually have heart and carotid blockages. Now, someone whose leg hurts when they walk, typically, until they just simply can't walk, don't seek medical attention. Problem is that's a huge mistake because that's a person at tremendous risk of dying of heart attack or stroke, because if you have blockages in your legs, you're much more likely to have blockages in your heart or your neck. It's not because if your leg hurts when you walk that you're apt to lose your leg. That's the small risk. It's that you're apt to die of a heart attack or stroke. But on the far end of that, many of these people do go on to lose their legs. We have pioneered many of the new techniques to save legs, things such as pedal arch reconstruction, where we actually go into the foot and go from the dorsal arch, or the arteries that run on top of the foot, into the plantar arch, or the arteries that run under the foot, and connect the two and dilate between them. Or pedal artery sticks, where we actually stick the arteries of the foot to come backwards. Or transcollateral reconstruction. These are techniques that people from around the world come down to actually observe and work with us to learn how to save legs in patients. But as much attention as we get for saving legs and healing legs and stopping leg pain, I really think that the bigger message should be that if you've got a decreased pulse in your foot, you should be worried about heart attack and stroke, because that's what kills these people.
It's a very kind of enlightening message, and not long ago and even now, unfortunately, the level of understanding that peripheral arterial disease directly translates to, or it's just a thumbprint of a more bigger problem, potentially life-threatening problem in terms of. So our practice is blended to them. If they come for heart problems, we not only are we worried about the heart, and we are kind of sweeping down and up, looking for problems, proactively seeking for problems elsewhere. In the past, that was led to people who didn't understand and kind of mistook us for being so aggressive in seeking out the other domains and trying to advise people, saying, and vice versa. And when they come with the vascular problems, be it carotid problem or they come for a leg problem, we are saying, well, this is fixed, but you really have to be digging deeper. And I guess indeed that led to the development of all these vascular labs and all that, which enable us to just pick them up, which typically takes 10 trips to different hospitals, are all done by our state-of-the-art vascular labs in one sweep. When they come in, if we suspect, if we listen, if we hear bruise or noises, or if we feel the pulses are not adequate, or if we feel an aneurysm in pressing somebody, we have state-of-the-art vascular labs, which will, in minutes, we can have a bird's eye view of the patient's vascular health and reshape our strategy for this patient. So that really is just one of the. And I was just really, to date, it's still most cardiologists that come to train with us still struggle with having that vascular support.
Well, it is clinically now what is accepted therapy worldwide. What we have been doing for a decade is now what is recommended by all of the major societies, in large measure because of what we published in the past and have shown. But people with diminished pulses in their feet die, number one, of heart attack, and number two, of stroke. So unfortunately, just getting blood supply to their leg is only part of the treatment. Okay, that's a small part of the treatment. You really do have to know what's going on with the rest of the patient. You have to do risk factor modification. You got to get this patient to quit smoking. You got to control his cholesterol. You got to control the diabetes. You have to control the blood pressure. And then on top of that, you have to make sure he's not a walking time bomb for a heart attack and a stroke. Now, these tremendous diagnostic procedures that we have let us do all of this in a much safer way to the patient, in a much more cost-effective way to the patient, because these tests done in the office are done at a fraction of the cost that they're done in a hospital. And they allow the patient to have these tests done in a single setting. So instead of a patient having to take a week off from work to get evaluated, the patient can get an evaluation in one day. Again, it's much as I've mentioned how I wanted my parents treated. My dad, in the middle of grinding season, he was a farmer, couldn't take off a week. If you could get him into the hospital or to an office for one day, you better get him worked up then, because you weren't going to get more.
That pertains to all of us, no matter how busy or important or not we think of our jobs. Really, we have only finite time, and this time. And let us just take a call from our dear Dr. Desitels from Appaloosa. Looks like he got tired of it. Line 2, Dr. Desitel. Dr. Desitel here. Sorry to keep you waiting. Go ahead. This is Cal. Go ahead and ask your question.
My question is, I've had Wolff-Parkinson White, which was zapped by Dr. Pat Welch of Lafayette. And recently I've had a little problem with my heart and stuff. So as I speak, y'all speaking, I have a monitor on, and I hope Dr. Welch figures it out for me. But I thought y'all might have some comments. I'm 83 years old, yeah.
Okay, let us go ahead and we'll comment a few lines on your question and just try and educate our audience. Well, he has asked somewhat, probably more to our electrician colleagues, but nonetheless, all of us are exposed to it during our training. The Wolff-Parkinson White syndrome that leads to this aberrant electrical pathways in the heart, which then in turn can set up circuits in the heart, which can lead to dangerously high rhythms, dangerously fast rhythms of the heart that can degenerate into cardiac arrest and potentially death as a result of it, because the heart rates can go as high as 260, 300 beats. And indeed, even though Dr. Welch, who is an electrophysiologist who does ablations and such, once the pathway is interrupted, typically there is a high rate of success in permanently interrupting that. But in these pathways, not only is there one established pathway, when one pathway is ablated, dormant several other pathways can cause reigniting of the problem, so to speak. So once the problem is successfully ablated, odds are it's probably cured. But if he's having palpitations again, it could be a different pathway or circuit that is again activated and leading to a different type of arrhythmia, not necessarily the one linked to his first arrhythmia or irregular heartbeat, but probably a different kind. So again, putting a monitor and actually picking it up to see what kind of arrhythmia it is. Is it something symbolic of Wolff-Parkinson White? Is it something of a different nature? And the other types of more dangerous arrhythmias or rapid rhythms could warn possibility of underlying coronary artery disease or blockages. So that is the other thing which also Dr. Welch or the other cardiologists, and I think Dr. Hammett takes care of him as a general cardiologist. So probably the onus is on them to look deeper in that aspect of care. So with that, we'll move on to the next, I guess the final section of our favorite sections that you kind of briefly broached on earlier on, is the translation of the so-called vascular, non-invasive vascular services, and of course the CT angiography, which you can spend a whole 1 hour talking about the whole merits and demerits of CTA and CT angiograms, which is nothing but necessarily doing an arteriogram, which traditionally we do it in or still traditionally it is done in the hospitals in majority of the institutions. Even in spite of it being, from a business perspective, investing in a CTA in our office is not the smartest thing, as some people say, but this moves beyond the business aspect of it. It just shows our passion about diagnosing this disease and in very state-of-the-art way, in a very precise way, and when we go to do an intervention to the cath lab, we don't have any confusion